So hello everyone and welcome to this ESU online webinar looking at the management of overactive bladder syndrome. My name is Chris Harding and I chair the EAU Guideline panel for non-neurogenic female lower urinary tract symptoms. If I can have the next slide, please. So the schedule for tonight's webinar will be 4 presentations, about 10 minutes each, and we've got plenty of time for questions and answers, and you can ask the questions through the Q&A box on the toolbar at the bottom of the screen, and we will endeavour to get through as many of them as is possible. This webinar comes accredited with CME, and it's 1 CME credit, but that will require you to complete the questionnaire after attending the webinar. And the next slide, please. So the program will be, first speaker will be Fawzi Farag, who will talk about the epidemiology, pathophysiology, etiology of overactive bladder and set the scene regarding this common disease that I'm sure you're all aware of. Then we'll have Dr. Mela Lapitan, who will talk about the pharmacological treatment of overactive bladder. That will be followed by Dr. Arjun Nambiar, who will talk to you about second-line treatment or third-line treatments really for overactive bladder, and he will be concentrating on sacral nerve stimulation and intravesical botulinum toxin. And then I'm delighted to say that Tina van den Bos will be speaking at the end and given us a unique insight into the patient's perspective on overactive bladder. As a panel, the non-neurogenic female lower urinary tract symptoms group has been very keen to amplify the patient's voice when it comes to lower urinary tract disorders, and we're absolutely delighted that that Tina will join us and speak. And then at the end, we'll take all of the questions together, but you can put the questions into the Q&A box as the webinar progresses. So without any further ado, we will start with the first presentation, which will be from Fawzi Farag.
Webinar. Hello and welcome to our webinar on management of overactive bladder syndrome. My name is Fawzi Farag, Assistant Professor of Urology, Sohag University Hospital in Egypt, and I'm currently based in Ipswich Hospital in the United Kingdom. Today I will talk you through introduction to the etiology and pathophysiology of overactive bladder syndrome. I have nothing to disclose. The EPIC study remains one of the most robust epidemiological studies on the prevalence of overactive bladder. It showed prevalence of these symptoms in women in up to 12.8%, with prevalence of urinary incontinence of any type, either urgency or mixed or stress urinary incontinence in women in up to 13% compared to 5% only in men. Prevalence of overactive bladder symptoms in women in USA was reported in LUTS study up to 43%. While Milsom study reported overactive bladder symptoms prevalence in 17% of women. Overactive bladder syndrome presents a financial and social burden on communities and health systems across the globe, with significant negative impact on quality of life of patients. Historically, overactive bladder syndrome was thought to originate from either myogenic, neurogenic, or urothelial dysfunction origins. This comprehensive work by Cornu and Pyrodin and their colleagues to identify clinical phenotypes of overactive bladder syndrome, hoping that someday we can come with individualized therapy for patients with overactive bladder syndrome based on underlying pathology. They categorized these possible phenotypes into 2 major groups, one of them based on the urodynamic finding of detrusor overactivity, and the other one based on the proposed underlying pathophysiological factors. Urgency originating from ultrastructural changes in the detrusor muscle fibers, leading to abnormal electrical coupling of the myocytes, resulting in aggregation of the physiologic micromotions into big detrusor overactivity waves. These patients show good response to all currently available treatments for overactive bladder syndrome. Urgency can also originate from dysfunction of the bladder urothelial or suburothelial linings, or even from spontaneous mucosal contractions. These patients present more often with urgency and frequency, sometimes with no detrusor overactivity or associated incontinence. They are thought to show good response to antimuscarinics, beta-3 agonists, and sacral neurostimulation. Urethral abnormalities can lead to overactive bladder symptoms. Entry of urine in the proximal urethra in patients with stress urinary incontinence can result in stimulation of urethral afferents and generate detrusor overactivity. This applies to pelvic organ prolapse patients where there is lack of support stretch receptors in the proximal urethra and the bladder neck. Both conditions can improve by correction of the underlying cause. In patients with urethral instability-induced urgency, these patients show good response to sacral neurostimulation, probably due to stimulation of the urethral function. They also respond to diloxetin, probably due to enhanced urethral tone. Urgency can originate from central nervous system. It has been shown that older patients with greater burden of white matter damage manifest with significant overactive bladder symptoms. These patients could respond to behavioral therapy. Also, sacral neurostimulation or posterior tibial nerve stimulation could trigger plastic reorganization of the cortical micturition network in these patients and therefore improve their overactive bladder symptoms. It has been shown that about 50% of patients with detrusor underactivity might manifest with one or more of the symptoms of overactive bladder syndrome. This can be due to reduced functional capacity, recurrent urinary tract infections, urothelial or myogenic dysfunctions. Clean intermittent catheterization stays the standard treatment for these patients. Metabolic syndrome, one of the major underlying causes of the overactive bladder symptoms. Urgency may occur due to increased sensory afferent stimulation of the trigone or the bladder neck due to mechanical load in morbidly obese patients. In patients with diabetes mellitus, insulin resistance results in pelvic ischemia and urothelial dysfunction. These patients may show better response to beta-3 agonists compared to antimuscarinics. Emotional stress, anxiety, and depression are important risk factors for development of overactive bladder symptoms in women. There is good evidence that women with depression-induced overactive bladder symptoms show good response to serotonin reuptake inhibitors and corticotrophin releasing factor receptor type 1 antagonists. However, sacral neurostimulation stays the most widely studied modality of treatment in this population. Estrogen hormone deficiency can lead to genitourinary syndrome of menopause, which includes symptoms of dryness, itching, and overactive bladder symptoms. This could be triggered by increased release of acetylcholine or connexin 43 expression. These patients show good response to topical vaginal estrogen in terms of improvement in the urgency urinary incontinence. Patients with urgency urinary incontinence show higher load of bacteria in their urine. This can generate brain-bladder microbiota axis leading to central sensitization. These patients show less favorable response to antimascaradings and Botox. Urinary bladder and colorectum share the embryologic and neural pathways, which might explain coexistence of some GIT and urinary bladder disorders. It has been shown that 1/3 of patients with overactive bladder symptoms also have irritable bowel syndrome. This could be explained by development of bladder colorectal crosstalk or cross sensitization. These patients show good response to sacral neurostimulation and posterior tibial nerve stimulation. Subclinical autonomic nervous system dysfunction can cause overactive bladder symptoms. It can be explained by one of two mechanisms that might overlap or coexist in some patients. The first is predominant parasympathetic dysfunction. These patients show good response to antimuscarinics. On the other hand, patients with predominating sympathetic dysfunction show better response to beta-3 agonist, probably due to restoration of the impaired sympathetic efferent pathway that elicits detrusor muscle inhibition. In conclusion, if you look at this figure, it summarizes the proposed underlying causes and pathophysiologic mechanisms of overactive bladder symptoms, either manifest with detrusor overactivity or due to other pathological factors, and the proposed tailored individual therapy per underlying cause. This is a very promising field for future research. However, as yet it can't replace the currently available guidelines, either European or American, in our daily practice. Thanks everyone, and have a lovely evening.
Thank you very much, Fawzi, for that most detailed introduction to the webinar. I can see a couple of questions appearing, and we will take those at the end. So we'll move straight on to the next talk, which is going to look at pharmacotherapy for OAB, and that's from my vice chair on the female LUTS panel, who is Mela Lapitan. Thank you.
Greetings, everyone. This session is about the EAU Guidelines on the pharmacologic management of overactive bladder syndrome in women. These are my disclosures. We shall discuss the evidence and recommendations on the use of anticholinergics, beta-3 agonists, and estrogens for OAB in women, and also mention the importance of placebo and nocebo. When we talk about medical management of OAB, we need to discuss anticholinergics, considered the mainstay in the medical management of OAB. There are a host of different anticholinergics such as oxybutynin, propivarin, trospium, tolterodine, solifenacin, darifenacin, and the newer ones such as imidafenacin and tarafenacin. Systematic reviews are consistent in showing that anticholinergics are effective, but are also associated with higher rates of dry mouth, cognitive impairment, and constipation when compared with placebo. All anticholinergics are found to be comparable, with no one superior over the other. Once daily or extended release formulations are associated with lower adverse event rates. Higher doses are more effective, but exhibit a higher risk of adverse event. Systematic reviews have also investigated the effects of anticholinergics compared with other non-drug treatments. Compared to posterior tibial nerve stimulation, pooled data from 5 randomized control trials showed that PTNS is more effective in reducing urge urinary incontinence than anticholinergics, but both are comparable in terms of other OAB outcomes. The same is seen comparing anticholinergics and intradetrusor botulinum toxin injections with better efficacy with Botox injections, but it was also associated with higher rates of voiding dysfunction and urinary tract infection. One randomized controlled trial comparing patients who underwent sacral nerve stimulation and those who received anticholinergics showed higher improvement rates in urge urinary incontinence and frequency among patients who underwent sacral nerve stimulation. Now, another important drug in the management of OAB is the beta-3 agonists. These include mirabegron and vibegron, and upcoming formulations such as solabegron and ritobegron. Evidence, mostly from trials using mirabegron and vibegron, showed systematic reviews showing beta agonists are better than placebo in OAB symptom improvement, but with similar adverse event rates. While anticholinergic use in the elderly is a concern because of its issue regarding cognition, this was not seen in beta agonists where mirabegron is shown to be both efficacious and safe among elderly women. Now, comparing anticholinergics and beta-3 agonists, 3 systematic reviews using mirabegron as the beta agonist comparator show that mirabegron is more effective in reducing nocturia than anticholinergics. However, it was not any different in improving other OAB symptoms in the short term. However, it showed better efficacy in the long term. Antimuscarinics were also found to have higher dry mouth rates, but with similar constipation rates when compared to mirabegron. One systematic review using vibegron as a comparator beta-3 agonist showed similar effectiveness with anticholinergics, but with less dry mouth. Now, combination drug therapies have also been investigated in several systematic reviews. Combining 2 anticholinergics resulted in greater decreases in urgency and incontinence, but with higher adverse event rates when compared to monotherapy. Combining an anticholinergic and a beta agonist was better in improving OAB outcomes compared to either monotherapy, but this was associated with higher adverse event rates. Now, based on these evidence points, the EAU guidelines offer these recommendations. Offer anticholinergic drugs to women with OAB who fail conservative management. Consider extended release formulations of anticholinergics when possible. If anticholinergic treatment proves ineffective, consider dose escalation or an alternative formulation, or the use of mirabegron as replacement or in combination with anticholinergics. Encourage early review of patients on anticholinergic medications. Offer beta-3 agonists as an alternative to anticholinergics. Offer mirabegron as an additional therapy in those who are inadequately treated with solafenacin. Now, a new section in the 2023 EAU Guidelines included the use of anticholinergics and beta-3 agonists, specifically among the elderly patients, particularly due to the potential impact of these drugs on cognition. Several systematic reviews of short-term randomized controlled trials show that anticholinergics are safe in the elderly, with inconclusive evidence on its impact on cognition. Pooled analysis on trials using beta-3 agonists showed similar findings. However, longitudinal cohort studies did show an association between anticholinergic use and cognitive deterioration. Hence, the EAU recommends that anticholinergics be used with caution in the elderly and that anticholinergic burden should be assessed when considering using anticholinergics for long-term OAB treatment. Now, in the context of OAB as a component of genitourinary syndrome of menopause, vaginal estrogen therapy is recommended based on a systematic review showing superiority in improving symptoms with estrogens compared with placebo. Now, an interesting section in the guidelines is on the impact of placebo and nocebo on OAB symptoms. One systematic review showed that inactive controls do result in significant improvement in OAB symptoms compared to baseline, but it also results in adverse events such as dry mouth and constipation. This emphasizes the need for comparative controlled trials on OAB treatment and the need to monitor patients over time, as they may initially report improvement even after ineffective treatments, only to worsen later on. In summary, pharmacotherapy for OAB presents many options, each with its own considerations. Hence, it is best to individualize therapy, taking into account each drug's efficacy and safety profile, the risks of the disease, and the risks of the treatment. More importantly, values and preferences of our patients must also be considered. Thank you, and I hope that you learned something from this short discussion on the pharmacotherapy for OAB in women.
Thank you very much, Mela. I'm sure that the attendees have learned an awful lot from that most comprehensive presentation, and we can refer you to our guideline, which is freely available online, and will give you all of the information and more that Mela has just presented. So we're going to move on now to the third presentation, which is given by my colleague from Newcastle, Mr. Arjun Nambiar, and he will be addressing third-line treatments for OAB.
Hello everyone, and welcome to this webinar. I'm sorry I couldn't be there in person today, but this talk is going to be on the third line treatment options for overactive bladder. Now, the aims of this talk are to give you a brief overview of the two main options in this category, which are botulinum toxin injections to the bladder and also sacral neuromodulation as treatments for refractory overactive bladder. I have no conflicts in relation to this talk. So the first option that we're going to talk about is botulinum toxin injections. Now, Botox, as it's commonly known, has 8 serologically distinct toxin types. And within that, Botox A has 5 subtypes. The most commonly used across the globe is onabotulinum toxin A, which is manufactured by Allergan commonly. But there are others such as Xeomin and Dysport, which is a B type of botulinum toxin, and Myoblock as well, which is used in other areas of medicine. A 100-unit vial of botulinum toxin A, onabotulinum toxin A, has 4.8 nanograms of toxin. And it's important to know that the lethal dose of Botox, because it is a lethal toxin, is 1.3 to 2.1 nanograms per kilogram when given IV or IM, and 10 to 13 nanograms per kilogram when inhaled. Botulinum toxin works by paralyzing the detrusor and hence preventing detrusor spasms, which are the hallmark of overactive bladder. The effect lasts between 3 and 9 months, and the injections are usually well tolerated under a local anesthetic. On the other hand, sacral neuromodulation, or sacral nerve stimulation as it's sometimes known, works by modulating the firing of sacral parasympathetic nerves at the S3 and S4 level, which supply the bladder. It can be effective in overactive and underactive detrusors, and usually requires 1 or 2 test stimulations to check the efficacy. The permanent implant is placed under a general anesthetic. The test phases can be done under either a local or general anesthetic, and the picture you see on the bottom right shows you the position of the battery in relation to the lead, which goes into the S3 or S4 foramina. The Medtronic website, Medtronic are the manufacturers of one type of sacral nerve stimulation device, which is called the InterStim, now the InterStim 2. And the Medtronic website has some very good informational videos for both healthcare professionals and patients to go through the mechanism of action, the placement, and all things related to sacral neuromodulation. So that's just a brief overview of the 2 treatment options, but let's have a look at the evidence for both of these options. The European Association of Urology Guidelines on the Management of Non-Neurogenic Female Lower Urinary Tract Symptoms recommends offering bladder wall injections of onabotulinum toxin A 100 units to patients with overactive bladder or urgency urinary incontinence refractory to conservative therapy or drug treatment as a strong recommendation, and also recommends offering sacral nerve stimulation to patients with overactive bladder or urgency urinary incontinence refractory to anticholinergic therapy also as a strong recommendation. They make no difference in terms of the order in which these can be offered to patients, and as mentioned, both are recommended as strong recommendations. The EAU Guidelines similarly make the same kind of recommendations in terms of these 2 treatment options. But there are some slight differences between them, and let's delve a little bit deeper into the difference between the 2 as far as the evidence is concerned. So in terms of patient preference, these studies which have looked at head-to-head comparisons between sacral nerve stimulation and Botox have mixed outcomes. So some studies reporting that sacral nerve stimulation is more preferred by patients compared to Botox, and others reporting the reverse, with some studies also reporting equal preference between the 2. However, a survey of UK urologists and urogynecologists who deliver these treatments seems to clearly suggest that the healthcare provider's preference is towards onabotulinum toxin quite overwhelmingly, and I think this is probably in relation to the fact that there is much more familiarity with Botox amongst these healthcare professionals. It is easier to perform as an outpatient procedure, requires less experience, and is deliverable in most centers, as opposed to sacral neuromodulation, which requires more experience, training, and more expert centers to deliver. Botox does have quite high long-term discontinuation rates, though, and studies which have looked at discontinuation rates beyond 4 years seem to suggest that that discontinuation rate may be as high as 60 to 80%. Some studies, our own center included, have reported rates as low as 25% after 5 years, but others have reported rates of up to 80%. So that can be an issue with botulinum toxin injections. Sacral neuromodulation, on the other hand, at least in American studies, seems to suggest that the efficacy is maintained to up to 80% up to 5 years. And this study in particular reporting well-maintained efficacy out to 5 years and in more than 80% of their patients. A long-term study from the Netherlands, from Maastricht, also reporting well-maintained efficacy for sacral neuromodulation beyond 20 years in their series, suggesting that at least 70% of their male and female patients reported optimal or at least suboptimal efficacy up to 20 or beyond 20 years since implantation. There has also been a randomized control trial looking into a head-to-head comparison between sacral neuromodulation with the InterStim device versus onabotulinum toxin A at 200 units in patients with idiopathic refractory urgency urinary incontinence, excluding patients with neurological disease, and a suggestion of voiding difficulty. And they reported equivalent or no difference in the mean decrease in urgency urinary incontinence episodes per day at 24 months between the two groups, perhaps a slightly higher efficacy for the Botox group at 6 months and even out to a year, but 2 years and beyond, as you can see in the graph, the lines seem to merge together, and there doesn't seem to be any difference in efficacy beyond 2 years. So I think in summary, what we can say is that botulinum toxin dosages and effects varies with subtype, and that's important to remember, and also by manufacturer. Botox is easy to perform, but requires repeat injections, on average every 3 to 9 months, and the long-term efficacy may be variable in individual patients. Sacral neuromodulation requires test stimulations before the permanent implant can be placed, and these need to be done at separate procedures and at experienced centers. The long-term efficacy of sacral neuromodulation may be up to 70% at 2 years, but infection, mechanical failure, and lead migration can occur. And perhaps the most important thing, given the evidence that we have at present in 2023, is that the choice of treatment should be based on a shared decision-making approach, and of course dictated by the experience available at individual centers. Thank you for your attention, and I'm sure the panel will be happy to take any questions on the topic.
Thank you very much for another excellent presentation. And the point that was made towards the end of the presentation there was the importance of shared decision making, which on our panel we are a huge advocate for. I think in order to engage in a shared decision making pathway, you need to take on board fully the patient's views, and you know, they're suffering from a disease, and as a clinician that would provide you from with a real huge amount of understanding with regards to the impact of the symptoms. So that's really nicely brought us on to the final presentation of the evening, which is from Tien van den Bos, who is going to talk exactly about the patient perspective and the patient experience of overactive bladder. So over to you, Tien.
To talk about the patient's perspective on OAB. My name is Tien van den Bos, president of the Dutch patient organization Bek en Bodem, which means pelvic floor for all. Together with Monica de Heide, also from B4A, and Marilyn van Poelgeest, president of the International Umbrella Federation of Patient Organizations for Incontinence, WFIPP, we are honored and proud to be the patient delegation of the EAU Non-Organic Female LUTS panel. So, what is it like living with an overactive bladder? In this presentation, I would firstly like to emphasize the impact of OAB on the daily life of patients. Overactive bladder syndrome can have a negative impact on the quality of life of patients and lower their self-esteem. This can cause a strain on relationships, including intimacy and sex life. It can be difficult to feel confident and attractive when patients do not always feel in control of their body and if they are experiencing urinary leakage. Patients with OAB may find they need to plan ahead to find toilet facilities. This may cause them to avoid trips to unfamiliar places. The frequent need to urinate can also cause patients to give up activities they used to enjoy, such as socializing or sports. Getting up at night to urinate can cause tiredness and affect one's mood. This may also wake partners by going to the toilet to urinate during the night several times. So it's important to encourage people with these complaints to go to a doctor to seek help, which is an important first step towards taking back control. Raising awareness for patients to seek help is considered by us, patients' organizations, as one of our main objectives. But it doesn't stop there. We also think that it's important for us to be involved in the assessment and treatment of OAB. Our input is based on the experiences and needs of the patients we represent and with whom we have a lot of communication, from Facebook focus groups, from telephone helplines for individual patients to group sessions throughout the Netherlands. And second, then, the importance of shared decision-making. Of course, it's not only about communication among patients themselves. Equally important is the communication between doctors and patients. As a doctor, your role is key when it comes to communication. Paternalistic advice from doctors is no longer the gold standard. Shared decision-making is increasingly being regarded as the norm. We think that a shared decision-making approach is paramount when any treatments are proposed. In the female LUTS guideline, this procedure is very well explained for the surgical treatment of stress urinary incontinence, but we think this may also be very useful for OAB, since there are a number of different options available for patients which may vary in efficacy and other patient outcomes. We would advise adherence to the following 7 fundamental principles of the shared decision-making process, and which include, at first, full participation of the patient. This is a relatively new role for patients, and we realize that not all patients will be open to this idea. For example, because they don't really understand or consider this too much of a responsibility. But we think it is important to give patients the opportunity to choose what degree they want to engage in decision-making. The advantages are evident: more satisfaction with and adherence to clinical treatments. And second, delivery of factual information regarding the benefits and risks of any particular treatment, if possible, adapted to the specific situation of the patient. The EAU website provides patient information about OAB, and a lot of countries have very good decision aids, like in the UK, the Patient Preference Elicitation Instrument, OAB Care, or the mobile application Patient Decision Aid for treatment of overactive bladder. It is important to use only reliable, high-quality sources and translate the information and make it quite specific to each patient. And then delivery of information about the experience and the expertise of the doctor who is going to treat, especially when it comes to higher specialized procedures. Such outcome data should be available in the public domain. It's not at all about judging doctors in a negative way, but specialized doctors, clinics, and hospitals may treat more complex patients and therefore have other outcomes. This is why we think the information about experience should always be given to patients with the necessary contextual factors. We also realize that this process of data management is difficult and expensive, but it helps doctors and hospitals to be aware of and continuously improve their results, and it can give patients more certainty and confidence. And then confirmation that the patient understands the information given. This may be quite difficult when you are dealing with patients who have low health literacy skills. It is even not always evident if you are dealing with this group of patients. It may be helpful when you start to explain in the most simple way, and only provide more detailed information once you see a patient understands it. The teach back method is a useful way to confirm that the information it provided is being understood by getting people to teach back what has been discussed and what instruction has been given. This is more than saying, "Do you understand?" and is a check of how well things have been explained and understood. And then clinician understanding and documenting individual patient preferences and facilitation of deliberation and initial decision-making. There are several methods to measure stated preferences. Survey-based approaches that ask respondents to express the relative desirability or acceptability of specific features that differ depending on the various alternatives and that reflect their respective underlying usefulness. And then patient opportunity to consider and confirm any decisions made. Give people and their family members, friends or carers as appropriate, the time they need to make decisions about tests, treatments, and interventions. And then last, clinician assistance with implementation of the final decision. We all should accept and acknowledge that people may vary in their views about the balance of risks, benefits, and consequences of treatments, and that they may differ from those of their healthcare professionals. At the end of a discussion, state clearly what decisions have been made to make sure that there is a shared understanding between the person and their healthcare professional about what has been agreed, what happens next, what the timescales are, and when it will be reviewed. And then last, the importance of collaboration in continence care. I would like to conclude this presentation by stressing the importance of collaboration in continence care. A patient-centered, integrated care approach to treatments is widely considered to be best practice, but it doesn't represent the current reality for many people living with incontinence. We believe that meaningful collaboration between scientific societies like the EAU and patient organizations like WFIBP is the best way to address the needs of patients and to effect positive structural changes within the healthcare system. We recently agreed 3 initial areas for collaboration. First, educating multiple stakeholders, including patients and caregivers, doctors and allied health workers, policymakers and funding organizations on the importance of shared decision-making, patient-centered care, and communication skills. And second, improving access to trusted information about incontinence issues for the general public, patients and healthcare workers. And third, embedding the principles of joint working within our organizations with the ultimate aim of influencing public and private healthcare structures to become more patient-centered by expressing our wishes for the near future. Needless to say that we need you, healthcare professionals, to be committed as well, as this audience most certainly is. I would hope this presentation can also contribute to that. So, collaboration and communication are keywords when considering the future continence care for both doctors and patients. Thank you for your attention.
Thank you very much, Tina, for a really interesting presentation, as always. We've had lots of questions coming in, so I'd like to invite all the presenters to switch on their cameras and unmute. And I'm just going to direct some questions that have come through to various panel members. So Tina, I'm going to start with you if that's okay. You talked about OAB giving patients daily symptoms, daily interference with their quality of life, and often some of the treatments may take time to work. And as one of the pillars of shared decision making, we need to give patients the opportunity to fully consider, their treatment options. And does rapidity of symptom relief, is that a big factor? How quickly will this treatment work? Is that something that patients hold a lot of stock by?
Now, it's depending on every patient.
Yeah.
Some patients will ask you for quick results, and other ones are more patient and say when there is no when I take the medicine, I don't want to have a dry mouth, etc., for instance. So it depends on every patient what is the best treatment option. So it is important to discuss together, doctor and patient.
I find that's really important when you're discussing the third line treatment. So for instance, when you're looking at sacral neuromodulation versus intrathecal botulinum toxin, the Botox will produce a symptomatic effect within a period of days, whereas the SNS, you will need a trial phase, then you will go forward for a permanent implant, and that elongates the pathway. So, the journey to symptom relief can be longer with SNS. But obviously the advantage is once that's finished, the SNS is a long-term, proven long-term treatment, whereas with Botox you have to reattend several times, roughly between every 6 and 9 months. So just another question, if I may, Tina, and you talked about the patient's understanding and information that's delivered, and that can be really difficult. And I've been a patient myself, and sometimes you don't retain everything that's in a consultation, and that's where I personally, as a patient, find that these adjuncts we use, such as patient decision aids, written information, direction to various websites. Is that something that you think we will get better at and increase in the future, to give then patients time to go through things at their own pace?
Yeah, I think it's important that we all offer the same information, and not every hospital his own information, his own website, but that we collect all and have that we are the same opinion about the information that is offered. And after that, it may sometimes some patients have longer time to think about things, or have questions after 1 week. And then I think it's really important to pay attention to this, because a good motivated patient the outcome of treatment will be better when it is understood by patient, and when he or she can see the consequences on the short term and on the long term, and really made his own decision, and then discuss with the doctor what you share the decision and you share the opinion.
Yeah, and I think something that really struck me in your presentation was the importance of individual clinicians auditing their own results and having their own results to hand. It's much more informative if you're a patient who's coming to see me, if I can tell you what my personal results are rather than the published results, because of course they may be different, better or worse. So I think that's really important. That's a good take-home message from the chat. So I'm just going to move on to Fauzi now, and just ask Fauzi, the current evidence base, do you think it allows for personalized OAB treatment, or are we some distance away? And if we are some distance away, might there be a space for big data collection, artificial intelligence to play a role?
Well, thanks, Chris. it's very nice question of you. If you remember in our meetings during arranging the updates of the guidelines, we raised this based on some of our findings from the latest systematic review we carried out, which was filtered to women with overactive bladder symptoms, and some of our preliminary findings were really obvious. For instance, the free agonists shown to be more effective in treating nocturia component of the overactive bladder syndrome compared to antimuscarinics. PTNS showed to give better results in patients with urgent urinary incontinence than antimuscarinics. As you mentioned, the lack of enough evidence is an obstacle to establish this module of tailored therapy for overactive bladder, but it is must, to my way of thinking, to be our future perspective in our research. And yes, artificial intelligence, of course, should help us achieve that.
So I'm specifically thinking about collection of maybe symptomatic urodynamic data and the sort of looking for pattern recognition and treatment outcome. And I think we are some way away from that at the moment. I'm just going to move on to Mela now, and obviously the most common thing we hear with regards to pharmacotherapy is the association between cognitive decline and antimuscarinics. So you know, you have obviously summarized the evidence very well for us tonight. Do you think we should be using anticholinergics in their current place, which is first-line treatment, or should we be thinking more about other potential pharmacotherapies to use as first line based on the evidence we've got with regards to antimuscarinics effect in cognition?
I think there's growing evidence really on the impact of anticholinergics, especially in OAB treatment. We expect long-term treatment. So as far as it being a first-line option, anticholinergics, perhaps we may start going away from that being first line, particularly in the elderly and those who already have signs of beginning cognitive dysfunction, and select other pharmacological. And there are, as we've seen, the beta agonists do not have the same impact on cognition, and it showed similar efficacy. So particularly in the elderly, I think other pharmacotherapies may be considered as first line to do away with this risk of cognitive impairment.
So I'm just going to put a question to a really interesting question has come through, and I put it to the clinicians, whether or not you should go straight to Botox without urodynamics, or would you do urodynamics first? So we'll let Fawzi answer that first.
Well, in recent practice, I started to see more and more patients having Botox without undergoing urodynamics. But to my way of thinking, looking at overactive bladder syndrome as a spectrum of diseases and symptoms that might overlap, we need to distinguish between patients who are straightforward suffering from diffuse overactivity based on myogenic deficit, and these patients can be treated and respond to all available treatments at level 1 of evidence, and other patients like patients with metabolic syndrome, affective disorder, sex hormone deficiency. These patients present more with frequency, urgency, hypersensitivity, not really manifest with the overactivity. And I think these patients could be a matter of question whether they go ahead with Botox without having urodynamics investigation together with treatment of the underlying cause, for instance.
And Mela?
I would probably be more towards doing a urodynamics first, particularly in patients who will give me significant post-void residual volume, or where I am when there is a possibility that the overactivity is more due to hypersensitivity of the bladder rather than problems really with overactive contractions. So especially that Botox is an invasive procedure, then I would probably do urodynamics first before subjecting patients for an invasive procedure.
Thank you. So I'm going to just take a few questions that came out of Arjun's presentation. So one of them was asking about to elaborate on the role of Botox. So Botox really prevents acetylcholine release from the nerve endings, which are at the neuromuscular junction between the parasympathetics and the detrusor muscle. And there are acetylcholine vesicles inside these nerve endings, and the membranes of the vesicles and the outer membrane of the nerve end plate needs to fuse, and then Botox is released. And Botox really will block one of these essential proteins necessary for that process where the membrane is fused. And if there's no acetylcholine released, or minimal acetylcholine release, then you're less likely to get muscle contraction. If you're less likely to get muscle contraction, you are actually treating the underlying abnormality, which is detrusor overactivity, which is defined as phasic contractions of the detrusor during filling. You've also asked a little bit about the mechanism of sacral nerve stimulation, which is really difficult to answer, and we don't really know. What we do know is that there's some kind of re-equilibration of the neuronal signals going into the sacral cord. We think the sacral nerve stimulation will primarily act on the pudendal nerve afferents, which will feed into the sacral cord. But there's also some evidence of a central effect. If you look at some MRI studies with patients who have their sacral nerve roots stimulated, you can see detectable changes. So I think the mechanism for SNS is less well understood than the mechanism for Botox. So I'm just going to move on and ask Fawzi to just expand on the answer that he's put in the chat with regards to the role of metabolic disease in OAB. I think that's really worth mentioning. I thought your answer was really complete in the chat, and I would refer attendees to that. But if you just want to go through that for us, that would be great.
Metabolic syndrome, including spectrum of disorders like hypertension, increased body mass index, or morbid obesity, insulin resistance. These patients have underlying causes of overactive bladder syndrome, and treatment of the underlying cause is the mainstay of improvement. And this has been shown or proven by less favorable effect of Botox and antimuscarinics in these patients. And interestingly, beta-3 agonists, namely the mirabegron, showed equal effect in obese patients to its effect on non-obese patients. And I didn't know before, but I learned recently that mirabegron was designed as body weight loss treatment when it was designed in the beginning, not as a treatment for an overactive bladder symptom. And again, these patients respond well and in terms of improvement of the urgent urinary incontinence and urgency after bariatric surgery. Mechanisms underlying overactive bladder, for instance, in obese patients, the mechanical load on the bladder is transmitted to trigone, which will hypersensitize central nervous system based on hyperactivity of the afferent fibers coming from the trigone, leading to detrusor contractions from the oversensitized efferent pathway. Insulin resistance might cause overwhelming ischemic changes in the pelvic organ, which might also lead to increased central sensitization and trigger the detrusor overactivity. Other factors like oxidative stress or systemic inflammation might lead to all this hypersensitization. And these patients, and most of the time, as I said, in urodynamic investigation, they don't show decrease of overactivity, but it's more in keeping with hypersensitivity of the nervous system and efferent neurofiber.
That's fabulous. So I'm just going to quickly answer two remaining questions that I think we've not addressed. So someone has asked whether idiopathic overactive bladder and neuropathic detrusor overactivity are related. So they're not. The definitions are very different. Idiopathic OAB or detrusor overactivity will occur in patients who don't have a neurological disease. They've also went on to say, is the pharmacological approaches, do they differ? Well, actually, they don't really differ too much, but you might find yourself escalating to second and third line therapies a little bit sooner in neurogenic detrusor overactivity, as it can be a little bit more difficult to treat. In terms of a non-evidence-based anecdotal impression from myself, I find that augmentation cystoplasty, which is a fourth line treatment for this condition, works much better in patients with neurogenic detrusor overactivity than it does with idiopathic detrusor overactivity. And the final question is, somebody had asked about the relationship between painful bladder syndrome and OAB, and they are quite different. Painful bladder syndrome the pain tends to get worse in a linear fashion as the bladder fills and it's relieved by voiding, whereas with detrusor overactivity, you get waves of pain which are kind of phasic throughout filling. So it is quite different, and that's only generally relieved for a very short time after voiding. And obviously the urodynamics will give you a clue as regards to the differential diagnosis, and other adjunctive tests like cystoscopy might prove useful, because in some patients with painful bladders you can see mucosal abnormalities. So I hope, firstly, you've enjoyed this webinar. I know I have. I'd like to give a massive thanks to all the speakers who made such a big effort with their presentations, and they were really brilliant and comprehensive. I hope we've answered all of the questions that you've posed. There is a bit of a question about how you get the certificate. You will need to complete a questionnaire following this webinar, and then you will be eligible for the certificate. There'll be a few questions there to check your learning. And in terms of whether the slides can be shared, I don't know the answer to that. I don't think the presenters would have any objection to sharing their slides. So it may well be that we can do that for you. So once again, I've been absolutely thrilled to see over 200 participants on this webinar. If you want to look for any further information, I can refer you to the non-neurogenic female low urinary tract symptoms guideline. And finally, just a big thanks for your attendance once again. Thank you.